My name is kroessner, and this is my presentation, Before the Storm, Palliative Care Referral Trigger Tool for Adults with Advanced Serious Illness. So I want to start my presentation with a question. What if you knew you were in your last year of life? I want you to think about where would you go and who you would spend that 1 year with. I'm just going to give you a second to think about it. Okay, that's probably enough time. I'm confident that no one thought to themselves, where I really want to be is in an ICU bed, hooked up to a dozen machines, or waiting in an emergency room for someone to come and see me and help me with my uncomfortable symptoms. And yet, that's the reality for many Americans. They spend that last year of life in and out of the hospital, calling their doctors, filling new prescriptions, and we all know and we can all feel that that's not the ideal. And many clinicians also feel at the end of life that their interventions aren't working. It's not something that's giving a lot of benefit to that patient and family. And families feel like they're on a roller coaster. Things might get better for mom or dad, and then they're getting worse again. But it's hard to know for both the provider and the family when it's time to get off of that roller coaster. So based on that question, I decided to look at how early palliative care referral affected the rate of high-value hospitalization, like ER admissions or ICU days, hospital readmission, hospice discharge, and DNR code status for patients that are in that last year of life. And access to palliative care is variable. Right now, it's very dependent on the provider identifying a patient who could benefit from palliative care and taking the time to have that conversation. And that's complicated if a provider isn't comfortable with having those discussions and the uncertainty. We don't know when is the right time to have those discussions. And they're busy. They're focusing on a complicated patient who needs a lot of different medications. They've got a lot of balls in the air. And so an intervention needs to be had. So current practice is that adults with advanced serious illness are often referred to palliative care relatively late in the life cycle and in the treatment cycle. So it's only after they've been to the hospital multiple times, they've been to the emergency room, they've been moved up from med-surg to ICU, or they're having a complete family crisis based on their family caregivers. This delay in palliative care prevents them from getting an additional layer of support. So they could have more unmanaged symptoms like pain or shortness of breath. They could have really unclear goals of care. They're continuing to do something, they're continuing treatments or medications that don't have clear clinical benefit. They could have a hospice referral really late in their disease process when they could have benefited from that layer of support. Their caregivers could be exhausted from taking them in and out of the hospital, adjusting to all these different changes in their medications. And so a standardized early palliative care referral trigger tool, that's a mouthful, can help clinicians identify these patients sooner. So before all of these emergency room visits and ICU stays, and help connect them with community support and symptom management tools to keep them in the home instead of pushing them to the hospital, and before the hospital becomes the default for the end-of-life care. So all that said, here's my PICO question. In adults with advanced serious illness, how does early referral to palliative care, compared with standard referral practices, affect healthcare utilization during the last 6 months of life? Well, here is a little bit about the evidence search itself. I searched these 3 databases, CINAHL, PubMed, and Medline, and I also use the ASU OneSearch function to cast a wide net over many different databases. My keywords were wide-ranging. I was trying to find as many different sources that can refer to my project as possible. And so you can see here, I've got my keywords, lots of ors, and these are all connected with an and. I'm trying to piece all these pieces together. You'll notice some English spellings, so I can capture some UK and European data. As you can imagine, there is not a lot of research dollars devoted to this specific field, but I was able to find some good information. So here's just a little bit more about the evidence search, my inclusion and exclusion criteria. Obviously, I wanted peer-reviewed publications in adults. I also was looking at articles within the last 7 years. There was actually a big research burst of interest about this topic in 2018, so I wanted to capture all of that data. I was also looking at studies that specifically talked about utilization outcomes rather than necessarily symptom management or caregiver opinions or feelings about these illnesses. So from those searches, I identified 5 articles on which I based my project that looked at how early referral to palliative care affected those health utilization outcomes. These populations looked at patients with kidney disease, frailty, cancer, COP, dementia, ICU patients, and other non-cancer serious illness. What's interesting about these sources is that they indicated in many ways that patients who don't have a cancer diagnosis are not getting palliative care services at the same rates as patients who do have a cancer diagnosis. It seems those prognostic tools that we have for cancer, or that cancer course that we know is going to happen, automatically is telling clinicians to look at palliative care, and that's not being applied equally to patients who have other serious illness. The strongest evidence for an early palliative care referral came from a randomized control trial that identified that a triggered referral led to the best outcomes. The evidence was credible, but it was mixed. I was pretty surprised. I thought this was going to be a slam dunk. Palliative care is going to automatically reduce all of these different measures, but it was very targeted in that the evidence showed that it reduced some, but not all. There's a big limitation in a lot of these studies. They varied in referral timing. For example, the randomized control trial, or an early palliative care referral, was 48 hours after admission to an ICU. So whether that's early or not, I'll leave that to you to decide. But even what is involved in a referral to palliative care wasn't necessarily clear. Was that just a doctor coming in and having a goals of care discussion, or was it a comprehensive review of the patient's needs and a plan? Here is the medications we're going to use to keep you comfortable as you go through treatment. So integrating all of this information, what we learned is that an early to palliative care referral is not a single guaranteed solution for reducing hospital care. So we can't just call palliative care and wave a magic wand and have them fix everything. But what we do know is that a systematic referral processes can improve the access to palliative care, can make the timing earlier in the disease process, and can help define the goals of care for patients and families, and help people get the hospice support that they need earlier in their disease. The benefits appear strongest for high-risk patients that have repeated utilization, folks that keep coming back to the hospital, and for folks that have functional decline, they can't do all of their ADLs, or they have a really high symptom burden and ICU illness. A big practice gap is the inconsistent identification of these patients, knowing who would benefit from a palliative care referral. And so a Turkish scorecard is a way that helps providers take themselves out of the equation and let the data from the patient indicate now is a good time to introduce the idea of palliative care in a way that is consistent across a healthcare system and that minimizes their hesitancy or discomfort. And so, my project intervention is an evidence informed practice guideline for adults with serious illness. It's designed for use in a hospital system that has an affiliated primary and specialty care network, and it uses a scored trigger tool to identify patients before crisis driven care becomes the default. And let's look at those triggers. So, here are some of the items that'll give you a few points on the scorecard. A repeated emergency room visit or hospitalization, if you've been admitted to the ICU, if you're experiencing weight loss or a nutritional decline, a functional decline, if you're changing from needing a walker to now you're needing a wheelchair, if you're having uncontrolled symptoms, pain, shortness of breath, nausea, dizziness, if you have unclear treatment goals, if we keep doing something but we're not seeing a lot of benefit for you particularly, if we notice that there's some caregiver role strain, or if the patient themselves is bringing up, is it time for hospice or is it time for comfort care? The goal is to support an earlier palliative care referral and support symptom management, support goals of care conversations, and timely hospice education when it's appropriate. So as we're deciding how to roll out this trigger tool scorecard, we have these questions in mind to see if this is even working. First of all, does the tool increase the number of adults referred to palliative care? So are we even increasing the palliative care referrals? Number two, does the trigger tool reduce the time from meeting the referral criteria to receiving that palliative care referral? Do clinicians report increased confidence in identifying those patients who may benefit from palliative care? Does earlier palliative care referral affect the healthcare utilization outcomes? Does it keep them out of the emergency room? Does it keep them from being readmitted to the hospital? Or does it help them get out of the hospital earlier and into maybe a hospice situation so they can go back home? Does it help reduce their time in the hospital? And finally, does earlier palliative care referral improve the care planning outcomes? Are we changing them to do not resuscitate? Are we having those goals of care conversations? And are we providing that information about hospice when it's appropriate? So what I would like to do before it rolls out is get some information on patients who have died in the previous year. A lot of reports can be run in our EMR, and we can run them retrospectively to see, okay, when would these patients have qualified based on that trigger tool, and when did they actually get a palliative care referral? And we can compare that data after the rollout of the trigger tool. And so what I really want to look at is referral rates, time to referral rates, a consult completion, emergency department use for these patients, admissions, ICU, all of those indicators. And so my interpretation of this would be if palliative care consults increased and were more timely, and we had improved goals of care discussions, then we would reduce this high intensity utilization during the last 6 months of life. We could determine that the project was a success and we could keep using it. Finally, I know that we can't know for sure when it actually is the last year of life, going back to that question I asked at the beginning. But what we can do is look at key clinical indicators that tell us that we need to be thinking more carefully about the time our patients have left. And we need to remember that referring to palliative care is not giving up treatment. It is adding an additional layer of support sooner rather than later. And we can take the weight of the choice of making that decision off of the individual providers and put it onto the data and let the data speak for us and speak for the patient. Thank you for listening to my presentation. Here are the references of the articles that I looked at, and I hope this was beneficial. And thank you again.